Good afternoon. I'd like to welcome you to Can Modifying Dietary Behaviors Modify Brain Health? Uh, this is our third session of Brain Boosters. Just want to remind you that on December 10th, we'll have our fourth and final session, which is for your popular demand of wanting to figure out how to extend the learning into your extension programs. So we'll have Erin Yellen from Kansas State, Julie Garden-Robinson from North Dakota State, and Chelsea Byers from Illinois, and potentially somebody from Florida. Next slide, please. All right, here is our team. I'm Julie England. I'm an FCS agent based in Seminole County, Florida. Dr. Wendy Dahl is in Gainesville in the Food Science and Human Nutrition Department. Wendy Lynch is an FCS agent in Putnam County. Kendra Zamoyski is a regional specialized agent for FCS in the Panhandle of Florida. And then our other members of our multi-state team are Carlin Raffey in Virginia and Julie Garden-Robinson at North Dakota State. Next slide, please. Just real quick information. Your link to the certificate of attendance is at the end of the Qualtrics evaluation, so please fill it out when you're done. And so we recorded it, and I will send out the links later for if you attended late or missed a previous one. Next slide. There, you should see the chat box. If you don't, hover over it, the bottom of your screen, and it should pop up. You can either email to panelists only or panelists and attendees, and we will answer your questions at the end of the session. All right, and with that, let's see, next slide. With that, I'm going to turn it over for Wendy Dahl for a minute to introduce our speaker for today.
Thanks, Julie. So it's my pleasure today to introduce Dr. Christy Tangney. She is a professor in the Department of Clinical Nutrition and Associate Dean for Research in the College of Health Sciences, Rush University Medical Center. Her expertise is in assessment of dietary behaviors of individuals and population samples in relation to cardiovascular and cognitive health. Much of her efforts focus on the development of short dietary screeners to monitor changes in dietary behaviors and key biomarkers of young, pre-hypertensive African American women, middle-aged and older women with cardiovascular disease, individuals with Alzheimer's or Parkinson's disease, and breast cancer survivors. Understanding what constitutes meaningful dietary changes in dietary stability within the limits of these tools is a critical component of her research. So welcome, Christy.
Thank you. Thank you for having me. And I'm very pleased to share with this conference what we've been working on for the last few years. So without any further ado, we should just go next. And I just want to make a statement that, in fact, I have no conflicts of interest. I'm showing a kind of a fuzzy picture here of the tower, which is at Rush University Medical Center, where our research lab is located. And you can see the owl is running right through the building, essentially, which it does. It's beautiful Chicago, although it's chilly right now. So let's get right to what the goals of this webinar are today. The first and most important thing is probably to lay the groundwork, and that is to clearly understand what is the difference between cognitive decline and how we define it, and how does this differ from Alzheimer's disease, which is the most predominant form of dementia in the world and as in the United States. And then I want to review the evidence for diet in particular, in some cases lifestyle, as a preventive for cognitive decline and incident dementia. And most often we will be looking at Alzheimer's disease if possible, if we have the numbers. I don't know, I've done a previous webinar about 4 years ago, and for me, is a very important opportunity to update that information for those of you who have maybe heard me before. First thing is to do somewhat of a discrimination. It's really very tenuous in the literature. What is age-related cognitive decline? So if we're looking over time in years, the brain ages, and most of us, we will manifest some loss structurally of our brains. They will atrophy. The cortical area will atrophy, just like any other system in our body. And what's considered age-related relative to Alzheimer's is a question of intensity primarily. But there are also certain functions clinically that we assess cognitively that differ, at least initially in the early signs. So I guess what we say is, you know, we know that brain AD is occurring many years before we actually see the signs of that clinically. And in fact, that leads to a very important concept that we will briefly discuss, and that is the idea of reserve or cognitive reserve. And typically it's believed that people who are more highly educated have a little bit more cognitive reserve, and that even they may actually present with more neuropathology than somebody with less education potentially. But it's because of that they have some reserve, so they have compensation mechanisms so that they do not experience the cognitive decline that somebody who would have less education might. And there are a number of factors that contribute to this. The problem is we don't all agree on how best to measure cognitive reserve or reserve capacity. So as our science evolves, we'll better understand those things, but those terminologies are used slightly differently by different investigators. So the concept being simply that there is a discrimination based on intensity of cognitive decline between those that are normally declining with age versus those who are experiencing clinical AD or Alzheimer's disease. And so before I started, I thought it might be interesting to just do a little short refresher. Most of us have forgotten like our biochemistry and our anatomy if we don't use it all the time. So on the left-hand side, we're looking at a sagittal view. A sagittal view literally cuts us longitudinally from the left brain to the right brain. So you're looking at as if we did a cut right down the middle of the brain. And we're looking at the frontal lobe here. And then the back is the occipital lobe, and you'll see the temporal lobe lies underneath. The temporal and the frontal lobes are particularly critical when we talk about cognitive decline and aging and Alzheimer's. And that's one of the reasons I wanted at least to you. And you'll know that the basal ganglial area is largely involved right here. You'll see the basal ganglia when we look at the coronal view. The coronal view divides the brain to the front and the back, from the belly to the front. So that's essentially what you're looking at here. So these things are, as we see here on the back end, and the cerebral frontal and the frontal lobe appear with our eyes forward. And this is the left and the right hemisphere. And of course, you could, in a lot of imaging techniques, you can take multiple cuts coronal-wise and piece them together so that you can actually see this 3D brain. Okay, so let's move on. So I wanted to present the idea that, you know, the other thing that differentiates between age-related cognitive decline and preclinical Alzheimer's disease is exactly where the biggest problems occur. And again, this is relative. It is rare. My colleagues here at Rush, who have a humongous brain bank in which they have these long cohort studies where individuals are continually measured every year, and at death, they donate their brains. And so we have an extensive ability to look at neural pathology at different points of the life cycle, as well as in relationship to imaging and relationship to biochemical markers and in relationship to diet, which is where this whole thing began largely for us. So the frontal subcortical circuits that in the front part of the brain are largely susceptible to microvascular and ischemia type damage, and that impacts primarily on complex processing speed and executive function. These are different types of domains cognitively that we measure. And so when Neurologists typically assess cognitive decline or even Alzheimer's. They go through a series of tests, cognitive tests, and processing speed, executive function, and on the right, memory performance, and many different types of memory performance are performed, but they're related to structural changes as well in the brain. So in preclinical AD, we're seeing a lot of impact on the mesotemporal lobe, that purple area that I just showed you, and cortical atrophy. And on top of that, with that cortical atrophy, the empty spaces in the brain, the ventricles are largely enlarging because the cortical area or the cortex is actually shrinking. So that contributes tremendously to episodic memory performance because consistent with that, there's loss of synapses and neurons at the same time. So the etiology, and this is the most simplistic way to describe it. There are many different layers that have actually been described over the years, but largely we recognize that neuroinflammation is still critically important. So the brain is on fire and inflamed with late onset AD, and cognitive aging may be this subtle chronic inflammation that goes on. Oxidative stress, obesity is well recognized. Part of the problem with most of our studies right now is we don't know how lifestyle has impacted on the neuropathology burden that's already there. And we have less of an opportunity to really look at that without extensive imaging. But the bottom line is, if you don't have healthy neurons and the ability to replace those neurons, you will not, you will start experiencing a decrease in function. And so I'm trying to highlight the three major areas that most studies will try to look at. They'll always, almost all the time, will look at loss of cognitive abilities as they measure neuropsychology-wise or clinically, cognitive testing. And that also contributes to some of the confusion in the area because everyone uses different tests. And there's been an effort on the part of NIH to create a cognitive battery that's standardized for all investigators to use, but it's still rather difficult to get people to buy into using the same standardized battery of tests. And when we make that leap, I think it'll be a lot easier to be able to understand across many studies. Then the other thing is to look at the actual neuropathology. Obviously, that can't typically happen, at least with our known techniques at this point in time, unless we have brains at death, at autopsy. And so that's where we will actually measure synapses, neuron counts. Our pathologists do this all the time. There are some newer techniques in which brain imaging will give us an idea of amyloid burden, will give us some opportunity to understand cerebral glucose perfusion. We'll talk a little bit about that, but all those things are highly sophisticated and take a lot of money. So, and it also means patient burden too. So the individual has to go through MRIs. Not that that's problematic, but it's claustrophobic to many patients. Many reasons why it's not easily done. Okay, so these are the kinds of things that we think about. Probably one of the earliest deficits that we recognize in early Alzheimer's is lesions specifically in one area, and that's called the hippocampus, which is this small area you'll see here deep in the midbrain, which is very small and has intimate circuitry through the temporal lobes and the frontal lobes. But at early points, we're going to see changes because of that hippocampal loss, and even imaging tries to measure the volume in the hippocampus. With that early loss, we're going to see mild memory decline, and then followed later by not only memory deficits, but language deficits. These are all different domains cognitively. Then followed by further visual spatial declines, and then finally abstract reasoning. So as we progress, these different regions of the brain are experiencing tremendous neuron loss and atrophy. So this is what we know at this point. And of course, I'm giving you a little cartoon version here, but one of the ways that we assess progression or even early stages of Alzheimer's or preclinical Alzheimer's is by looking at these components, the plaque and neurofibrillary tangles in the brain. And we can look at that with some imaging. So you can be, I mean, this can be done on live individuals. It also can be done by sampling the cerebral spinal fluid that bathes the brain. And so for a long time, we were concerned that maybe we don't understand what's happening actually in the brain tissue relative to that bathing tissue, if you will, the plasma of the brain called CSF, and how that may be a relevant marker. So there's been a tremendous effort in the last decade to look at these markers so that we could track cognition changes, clinical changes in relationship to these biomarkers, in relationship to this imaging. So that's been the strategy all along. What's really critical here is that we also measure diet in the same way, that we measure diet continuously, not assuming that we measure it once and it's predictive of future. Yes, that's important, but people don't do the same thing with their diet continually. We change. So it's really important to do this serially. So this expands, this comes from the MAP. MAP is the Memory and Aging Project, which is an ongoing project here in Chicago led by David Bennett, from which we have published a lot of data. That is my colleagues and I, Dr. Morris and I, and I'll refer to some papers in which we have define certain dietary behaviors on the basis of looking at this in relationship to these series of tests that look at the decline or change over time. So in this particular cohort, these cognitive measures are measured every year in individuals. And they live in the greater Chicago area, and so we have people going out there administering these standard tests who have been highly trained to do these things. And they're averaged and they give a global score, but then we have specific domains as listed here: the episodic memory, semantic, working, visual spatial, which we said would change, and the perceptual speed, which is often more associated with ischemia. But as I said before, rarely does one present strictly with Alzheimer's. They will have some cerebral vascular disease at the same time. It's rare that one will present with one clean diagnosis. So all those things are taken into account. But the value about diet and other preventative lifestyle measures are things that we can actually manipulate and modify. So what I show here is actually some neurofibrillary tangles as well as some plaque. But on the background, I'm saying years of education, the amount of social engagement, we really believe those two are very critical in contributing to cognitive reserve. So one of the most important things for my mom when she was suffering some of the early days of, I thought, cognitive decline was allowing her to be in a setting where she would constantly interact with other people socially so that she'd keep that social engagement going on. At years of education, once that's done, it's typically done. Although for many of us, we can continue to educate ourselves, whether we are retired or not, because there's tons of continuing education to do. So those are the great values of the lessons we should learn and impart to others. And then of course, diet and what we call physical and cognitive play. That is gaming. What we've learned recently is that there are certain kinds of gamings, especially we can say all we want about computers and cell phones, but we can use them to our advantage to engage people cognitively in active play that involves many different domains at the same time. So that's part of the strategy involved, and I'll tell you a little more about that as we move on. And this overlying theme, partly because we had so many big trials. Cardiovascular disease has been in our country one of the major burdens that we've experienced, and it has quickly now moved much more to neurodegenerative diseases. But the thought has been, let's maximize those cohorts, those studies in which we have looked at protecting the heart, and can we then understand by protecting the heart, could we protect the brain? And largely because some of those same modifiable risk factors that appear to be so important are the same ones that also work for cardiovascular disease. And I have to tell you that in the last 5 years, we've grown greatly from moving the type of evidence from observational cohorts, particularly prospective cohorts, where we measure people repeatedly over time, but we're not looking at final outcomes like Alzheimer's disease, but we are looking at cognitive decline, to things where we might also test things in a more clean sense, that is randomized clinical trials. But to move from cohort to clinical trials, we have to have a much better handle on the specific manipulation or experimentation that we want to test, because it has to be very defined. And in being very defined, we limit those other possibilities. So I often tell people observational cohorts are critical for hypothesis generation, but this is largely for hypothesis testing. And that can be somewhat problematic sometimes, because once you've tested something and you proved it incorrect or correct, that's a dead end to some degree. And we have to go back to that generation and decide, okay, what new variation that may be. So we're at that stage of looking at this right now, this transition insofar as the science. And I don't know if you've been fortunate enough to read some of the recent editorials that have appeared in various news things, but you know, nutrition is not funded highly. It is one of the most poorly funded sciences ever. And we're not going to learn much if we don't invest in funding in these areas. So these are the number of healthy diets that have been proposed for cognitive health. And I'm going to go through a few of them because initially they were proposed largely for cardiovascular health. And the first and foremost I'm going to talk about really are the two on the far right, and that is the Mediterranean and the DASH. But I've been involved in many of these myself with my other colleagues, so I have some firsthand information I'd love to share with you. So we're going to talk about the Mediterranean diet. And I'm sorry if I've shuffled a few slides. It's because I thought the story would be told better, but I have not removed any slides from the slide deck, so please understand that they're all there. So one of the biggest problems with the Mediterranean diet pattern, it's hard to define it. First of all, every area along the Mediterranean Sea has a slight variation thereof. And probably the most compelling data has come from Greece and Spain. And their diets are even slightly different from one another. We've developed various tools. The Greeks have developed some wonderful tools, and we have adopted some, but in that adoption, we've kind of simplified them, in my mind, oversimplified them. So you're going to see, at least I had a graduate student reviewing it, there's probably 15 different scoring ways to score Mediterranean diet. So you have to be careful. You also have to be careful what it's based on, because the more comprehensive your diet assessment, the more confident you can be that you're really characterizing the diet appropriately. So I was very fortunate to work with a lot of colleagues in the MAP and the CHAP. The CHAP was earlier than that. This MAP is that memory and aging cohort. And we looked at two primary dietary patterns. In 2011, I looked in CHAP at the Mediterranean diet using the same tool. This is called the Med Diet tool. And what's represented here is this global cognitive score, and it's changed over time. And so the beauty of this MAP cohort as well as CHAP is we have at least 15 to 21 years of data where we have repetitive diet measures in them. And so on the far right-hand side, you're seeing people who are characterized or classified into tertiles. So tertile 3 means that your dietary score for med diet is the highest possible. So in this particular tool, this tool ranks you from 0 to 55. So anyone who was, say, 45 or higher was classified in this particular tertile. And subsequently in tertile 2, you're in that middle area, and tertile 1, you're in the lowest level of adoption. Now remember, these people are just reporting on an FFQ or food frequency questionnaire. They know nothing. They're not aware of the fact that I'm scoring it as a Mediterranean diet, or on the left-hand side that I'm scoring it according to a DASH diet. And I'm going to tell you briefly a little bit about the differences between the two of those in another slide or two. But this was the beginning of our understanding and our thoughts about those who are most adherent to a Mediterranean diet, and likewise to a DASH diet, were the ones who had the slowest rate of decline. And because they had the slowest rate of cognitive decline, we felt they're being protected. And in fact, these folks in this one are being protected about 7 years more. So it took 7 years more than the folks here to experience significant decline. So that became an important issue to us. And I am not the only one. Our group is not the only one. There's probably over 100 studies now that have looked in cohort studies of the Mediterranean type diet in relationship to cognitive decline. Everyone using slightly different tools to measure Mediterranean diet, everyone using slightly different combinations of cognitive measures, but generally the message has been consistent that there is roughly, based on a recent meta-analysis, roughly a very dramatic reduction in the rate of decline. And when we look at mild cognitive impairment or Alzheimer's, we're looking anywhere from 27 to 36% reduction in the development of mild cognitive decline or Alzheimer's in these cohort studies. And they believe that much of the benefit is related to cerebral vascular risk. So it's going to be executive functioning, those kinds of things, and reduce incidence of brain infarcts, not necessarily exclusively only memory issues. So these meta-analyses are very important to tell us where we're at, but we need to really have stronger evidence. So remember, we talked about the fact that protect the heart and protect the brain. Well, the earlier clinical trials were addressing heart disease. And really about 2013, we had one of the largest diet trials that have ever occurred. One other one in our country was the Diabetes Prevention Program. But in Europe, specifically Spain, they did a clinical trial where they looked at the Mediterranean diet against the low-fat control diet. Now, there were some problems with this trial, no doubt about it. And I'm not going to talk extensively about some of its limitations. They did some reanalysis and the same outcomes were largely found. And that is the following. Well, let me first tell you a little bit. These individuals were high risk. We're looking at nearly 7,500 older adults, and they've never had coronary or cardiovascular disease, but they are extremely high risk. They presented either with diabetes or 2 or more coronary risk disease factors. So a host of factors were used, and if they were enriched in these factors, they would be enrolled in this study. And this study was unique, even unlike the Diabetes Prevention Program, because it was the diet was rolled out by dietitians, and it was rolled out by dietitians who met or followed up with the participants at least monthly. And they filled out screeners, and they did FFQs, and they got extensive instruction on how to adopt a Mediterranean diet. And of course, you will know, we're in Spain. They already had a Mediterranean diet. But as most of the world has changed, most of the world has been westernized. So every family would get extra, that were assigned to treatment 1, would get extra virgin olive oil sent to their home so that they would consume it. If they were assigned to the Mediterranean group number 2, they would get 30 grams per day of a mix of walnuts, hazelnuts, hazelnuts and almonds every day. And if they were on the low-fat control diet, they were given coupons for various low-fat products. So they really tried to help people adhere to the diet. And the results of it were dramatic, that in both, what we're looking at here is the incidence of composite cardiovascular endpoints, that is stroke, cardiovascular death, and acute MI. And this is blown up on the far right, and you can see that there's a dramatic break apart or discrimination within 1 year. Within 1 year, these two groups have a remarkably reduced, about 30% reduction in cardiovascular events, this combined endpoint. So this really, really changed it. And having looked at that, I was, as much of America has the Dietary Guidelines, really finally recognized that, you know, you can eat healthy fats, and those healthy fats will be associated with cardiovascular outcomes. And so the emphasis, you can see on the far right, you all know this, it's not new news to you, but it took a while for that to be adopted, as you well know. Dr. Morris and I looked at this, and you know, we're privy to a lot of neurologic data that we were looking at, cognitive decline and all these different cohort data. And we said to ourselves, why don't we look at our cohort data and see if we created a new score beyond the Mediterranean or the Med Diet score that we had used, or the DASH score. Let's create a new score. And that gave rise to what we now call the MIND score. And what we wanted to do was incorporate more, and I really should have accentuated this. We wanted to incorporate not only more blueberries, which is unique to the MIND diet, where the Mediterranean diet looks at all fruits. We don't look at all fruits in the MIND. We only look at blueberries. And we also have a special emphasis, not to say that other vegetables are not important, but we have a special emphasis on green leafy greens. So those leafy green vegetables are the ones that are really important. And of course, like the Mediterranean, wine, a regular but low dose of wine is important. Our question is whether other fruits are critical here. Both the DASH, both the Mediterranean diet, all of them emphasize other sources of protein in our diet, including nuts, legumes, and fish. And then simultaneously, what I think was really unique about PreDimed is they also focus on the things that we should avoid. And that is not only talking about processed meats and low-fat dairy, but they talked about commercial pastries and cookies and desserts and fast foods. So that gave rise to what we call today the Mediterranean DASH intervention for neurodegenerative disease, which we then coined the term MIND. And if you look at the next slide, you'll see the specifics of the things that were emphasized. So that is, the other thing that's unique about this score against some of the other scores, not Med Diet, but some other scores that you see in the literature, is that you have a midpoint. You get some credit for going halfway, if you will. So in other words, if you don't consume 6 servings per week of green leafies, but you do something more than 2 and less than 6, you get a half a point. Same thing with berries. If you don't consume 2 or more servings per week, you'll get a half point if you get 1. And then once again, looking at a moderate dose of wine. And I have to say, most of America was very hesitant to even make that recommendation. But as part of the European and Mediterranean culture, that's part of their culture. So it was not a hard sell for them. Notice that fish is not as high as it is in the Mediterranean diet. Usually fish is recommended 3 times a week, depending on which score you're looking at. This is saying you're probably okay with just 1 or more per week. There's no added advantage going higher. Once again, same thing as Mediterranean, olive oil is the primary thing used. And when we've looked at this, now remember, this is an observational cohort, the MAPT cohort. We looked at it in 800 individuals. And we looked at the score that we created, and we found not only did it predict slower cognitive decline, but it predicted incident AD, or Alzheimer's disease. So as you had more and more adherence to the diet, being in tertile 3, you had much less of a chance of developing Alzheimer's disease over this 8.5-year period. And so again, knowing that this is an observational cohort, Martha Claire and I decided to go ahead and design a clinical trial, which is known as the MIND clinical trial, which is ongoing right now. So the MIND diet was created from dietary data and examined in relationship to incident AD in an observational cohort. And the reason why I'm making a big deal about it is this is not the final proof of concept here. What we have to do is see if we educate individuals like they did in PreDiva, and we educate people on the MIND diet, will we experience some decline in incidence AD and a slowing of cognitive decline. So that's what I'm trying to emphasize here, that we make that distinction, that you make that distinction to your clients, because it's not all together yet. You know, we've been through this before with Women's Health Initiative, where he felt like all the data was there, and we have to be conservative here. And what started us even more onto this thing was because in 2015, the cohort that was in the randomized clinical trial, some of them at a certain site had cognitive measures acquired both at baseline and at the end of the trial. That was not required in the larger trial of 7,500 individuals. But in one of the cohorts, it was done. They had additional monies that they put aside for this. And so they were able to do a secondary analysis, and they wanted to look at this because they saw all this Mediterranean cognitive decline and incident with the MIND, and they said, wow, we need to look at this. And so the PreDiva team looked at these 3 arms and looked primarily at these cognitive tools, which really fall into these 3 domains that they summarize: a memory domain, a frontal, which is the same one that we talked about, that's usually very involved in age-related cognitive decline, and then a global, which incorporates all of those. So as you look at this figure, you can see the following things, and I just want to walk you briefly through it because I know I'm tending to talk too long. So the control is the dark blue or aqua, whatever you want to, teal. And in every case, over the 4.5-year period, we're seeing declines, significant declines in all of these scores, whether it be memory, frontal cognition, or the global. But what we did see was that compared to controls, the memory was significantly improved in those who were assigned the Mediterranean diet and given nuts. So those individuals actually did not experience that rapid decline, and they actually look like they improved slightly. But regardless, the difference is significant, and it really doesn't look all that, it looks impressive. Likewise, when we looked at the frontal cognition, which I think is really attesting to the cerebral vascular input, that the olive oil arm, active arm of Mediterranean, was associated with very dramatic differences and increases in the composite score for frontal and global. So both of these were dramatically improved relative to the control. So again, a secondary analysis is not the end-all be-all, and so there's other studies that have to occur. I also, because remember I was telling you that we need multiple triangulations. So what's happening with brain imaging during this period? This was all based on cognitive clinical assessments. So there was a very interesting paper from the New York group that looked at 70 individuals, and they did FFQs at only 1 point, or food frequency questionnaires, but they use these interesting markers They used a marker for its PET scanning marker that gives us a picture of the amount of beta amyloid. And we talked about beta amyloid and tau being primarily kind of signature markers for Alzheimer's disease. And then they also looked at the amount of glucose metabolism in key regions that are usually affected by Alzheimer's. And so if you go to the next slide here, you're going to see that MEDI minus is those individuals over time that are experiencing load increases. And if you can see this, these are experiencing substantially more load increases in this affected area as compared to the MEDI. In other words, those who are identified as having a more Mediterranean type diet. But again, there's problems with this. This is only cross-sectional, really. Even in a longitudinal sense, we're looking at 70 individuals. This is not the end-all, be-all. So it adds a little more data, but it's not enough. So let's talk about the evidence that we have for the DASH. You saw my data on the observational cohort. Are there any clinical trials that actually address that? And maybe just because most of us are not used to all these scoring techniques that are done. In this slide, I'm showing you basically the differences between the DASH, the Mediterranean diet, the MED diet, the one primarily we used, and then the MIND diet. And this is how people get the maximum score. And you'll notice there's 15, 10, and 55. So you have a lot more chance to see some discrimination with the MED diet, but the MIND score did remarkably well. But to bring the emphasis back on the DASH, what DASH focuses on here is less about whole grains and more about fat. And one of the reasons I love the DASH, I mean, it's a very effective tool, but when you're trying to educate patients, they need to talk about foods, and that's really critical, which is why these tools are much more useful in a lot of ways. However, they do spend a lot of time. The classic original DASH never involved sodium, but there was an add-on, and it showed how powerful sodium was in relationship to blood pressure measurements, what DASH was originally designed for. So let me move on because time is a-wasting. So we do have a short-term trial. It's called Encore. It specifically looked at older, middle-aged and older adults. But what's key here, you'll notice, is we're starting at 52 years of age. This is the mean age for the 144 individuals. And originally, the study was designed to look at blood pressure measurements and metabolic outcomes. But a secondary outcome they designed in their trial was looking at executive function. And that executive function, memory, and learning was a composite they called EMFL, which stands for the first letters of each of this. And then they also did one for psychomotor speed, or complex speed processing. And what they demonstrated here is in the individuals who had both physical activity and the DASH instruction, they experienced the most important increase in this executive function, memory, and language. And that was significantly different than the usual control. There was no difference between these two groups. So when they did DASH alone, that was not meaningful. However, when we go to psychomotor speed, both DASH and DASH plus exercise, which is represented as WM, which is weight management, because these individuals were trying to lose weight, experienced significantly improved psychomotor speed. So this was another suggestion that the DASH diet was important. And you notice the date on this. This was at the same time we decided to start making the MIND diet. There was another trial that followed in this by the same group, and this looked at a 2x2 factorial design where they were looking at an additive effect of exercise and the DASH diet, whereas the other one was looking at one combined, one with diet alone and usual care. This one is looking at them as an additive or a 2x2. And in this case, with Enlightened, based on the name you'll know, the primary outcome here was composite executive function. And once again, here is the aerobic exercise and DASH. And when we look at global executive function, we see a dramatic increase, a significant increase in, once again, executive function with the combination of both. There were no significant differences between these groups. The clinical dementia scale was almost significant, but was not. And again, this is a short-term study, 6 months. One would not expect major changes. When they looked at predictors of executive function, again, a secondary analysis, cardiovascular risk, fitness, and reduced salt intake were the most important correlates of improved executive function in this short-term trial. So once again, giving us a sense that lifestyle is important here, not only diet. And I just want to hit upon probably one of the newest papers that has come out, and many of you probably are aware and have heard a lot about ketogenic diets. And I wanted to at least touch on this one because I was asked to review this paper, and it's now in preprint state in the journal. And so I wanted us to at least be aware of it. And, you know, the ketogenic diet's been around for almost a century now. And it has been viewed primarily to help individuals, particularly children, with epilepsy, because there was known associations, and that is associations with seizure reduction. But there's been some additional work that's been done on some small studies, small clinical studies on the order of 20 people that have looked at this and have also looked at this in animal models. The only problem with animal models is there are very few rodent models that mimic the kinds of changes that we see in the human with regard to Alzheimer's disease. So it's been difficult to use animal models in this capacity. But overall, rodent models are still being used initially to test these hypotheses. So there's a randomized crossover design, meaning that each individual, however small this data is, small number of samples, is exposed to both diets. So what happened is these individuals were exposed to a ketogenic diet that was Mediterranean based. So you know that the ketogenic diet is very enriched in fat, almost 70 to 90%, depending on how rigorous the diet is applied. And the thought is that if we can make it a Mediterranean diet, it'll be a healthier diet. So they applied a Mediterranean ketogenic diet. A dietitian was extremely involved, did multiple educations and tracked diet with 3-day food records during this short-term study. And again, once again, short-term study. And measured, though, what was interesting about this is it not only measured diet, but it also measured CFS markers. It looked at some of these amyloid markers in the CSF. It looked at perfusion, once again, through imaging, and it traced the amount of uptake of ketone bodies, as well as looking at memory performance using cognitive tests. Now, I'm not going to show you everything because it's such a small study, but what this is illustrating right now is that, in fact, there is an improvement in biomarker profiles with the this is pre and post. So you're looking right now at the modified Mediterranean ketogenic diet, and here's the low-fat diet. And what we're seeing is dramatic improvement in the biomarkers that we see in the CSF, suggesting that there's loss or lack of deposition in the brain. Again, a big step, but nevertheless, I don't show you here exactly, but this is looking at perfusion once again. And this is looking at glucose perfusion. And once again, in those individuals, or when those individuals were on that diet, they experienced more intensive perfusion in key areas. And that's what you're seeing here, that light up area as time goes on. So this is an impressive study, but it needs to be followed up. for more long term. And so what I can tell you right now is there's several trials that are ongoing testing the efficacy of the Mediterranean diet. There's more on the DASH. I know there's at least two going on in the ketogenic diet, and definitely the one of ours, and there's actually 2 other sites that are doing another version of the MIND diet. So there's multiple studies going on with this. And then finally, I want to go over at least 1 or 2 really compelling multi-component lifestyle approaches. They use both diet, activity, and cognitive training in most cases. So let me move to that. Probably the most compelling one is that of the FINGER trial, which stands for the Finnish Geriatric Intervention Study to prevent cognitive impairment or disability. This is looking at 1,250 individuals who were between 60 and 77 years of age, who had cardiovascular risk factors and some indications of neurocognitive weakness. This is a short-term trial. It's only 2 years, and they were looking at improvements in neurocognition in a composite measure. And so this is kind of the layout of it. This is the paper. This is the actual one of the many papers that was published from this. This is looking at the 24 months, and this is how they rolled out the intensive intervention, and the opposite was just regular health advice. So 2 extremes, one with intensive intervention. We had 6 nurse visits, 4 physician visits, cognitive training 3 times a week for 6 months. Then later, it was 2 group sessions and still 3 times a week for the follow-up 6 months at the end. Physical activity supervised initially, then later on their own. And nutritional counseling, 7 group and 3 individual. The diet wasn't specifically Mediterranean or DASH. It was consistent with the Finnish recommendations, but very similar in domain. And this is the outcome. So in global cognition, what we're looking in the intervention group, which is the red line here, that we see an improvement over the 24-month period. We start seeing that divide at 12 months, and that we're looking at a 25% improvement in overall cognition. And then with various components, you can see executive function, once again, improved most dramatically, processing speed, again, largely attributable to those cardiovascular frontal parts, and then, but still, a memory improvement. So this was a powerful study. This was extremely powerful, and that's trying to be mimicked now with the Pointer trial here in the United States and other trials in Europe. So we're looking at multiple diet, cardiovascular factor modification, physical activity, and cognitive training. So let me move on to 1 or 2 more. Unfortunately, many of these, so this last one too is secondary outcomes to the FINGER trial. They looked at MRI markers. They did not measure this in everyone because of costs involved. And so you had 132 at the baseline and 112 in the end. And the most improvement they found was in cortical thickness in regions that were largely tied to AD areas. But again, not a big effect, but very surprising even in 2 years to see that kind of change. The biggest issue was that in their sub-analysis, they suggest or find, and again, this can be dangerous, that there was more benefit in those who had less advanced neuropathology. So once again, addressing the idea that we're still in these early stages. If people have more burden, what's more important? Should we emphasize more exercise? Should we emphasize more diet? We don't know those. And with a composite study like that, we will not know that. We still need those independent studies to tell us that further. The PreDiva, I'm going to go through this quickly. It was looking at 3,500 plus adults at different healthcare centers. It was a cluster, so each center was randomized to either the multi-component or usual care, and they studied individuals for 6.7 years, which is a long time. And in this case, they weren't looking necessarily at executive function, they were looking at incident dementia. So that may have been too short, because it's unfortunate in this study, we really didn't see a strong effect on all-cause incident dementia. There was no effect on mortality or cardiovascular disease or disability. However, there was an improvement in systolic blood pressure. So that may have been because it was too short. It wasn't intensive enough. There's many reasons why this may be. Let me move you to the last really big multi-domain trial, which was called the MAPT, or the multi-domain Alzheimer's Preventive trial. And that one, they looked at a factorial design. So either you got the multi-domain or not on the left-hand side, or you got the omega-3. So in one instance, this group here, you got both. Here you got just the multi-domain. Here you got omega-3 alone. Here you got placebo plus placebo. And the multi-domain is such, but I'll have to tell you the nutrition advice was very limited. It was 15 minutes every few months. So to me, that did not represent a strong. And after 36 months, there was no significant difference in cognitive outcomes. There were some small improvements in the combined group, that is a group who got omega-3s plus the multi-domain. And those who had the highest risk of dementia, in other words, when they came in, they had the highest score, had the most significant change. But again, these are secondary analysis. So we wonder, is this too late? Did we start too late? Should we start in middle age? Did we have too little nutrition advice? Was it too little intensity? All those questions need to be answered. And right now, these studies are going to be pooled, and they're going to be continued in what we call the European Dementia Prevention Initiative. So those people in all these areas, that is Finland, Dutch, etc., are going to be pooled together and followed up futuristically, so that we have a larger study to design and to look at more outcomes over time. Oh, sorry. So the next slide I want to show you, and it's my end. I'm sorry, I'm going a little over. We designed a trial, and this is not primarily me. This is my colleagues down in Indianapolis who designed a study to ask the question, if we designed a MIND-type diet that is enriched in polyphenols, could we see an improvement in executive function? And so the reason why I bring this study up is because there's been some very interesting studies looking in short term of cocoa. You probably heard a little in the literature about short-term trials looking at cocoa shakes, and cognitive function over time. Blueberries, there's been some very interesting studies, but they've all been short-term. We published a paper on polyphenols, and that is a very complex series of compounds that include multiple classes. And when we look at blueberries, we're largely looking at the anthocyanins. When we're looking at the cocos, the nuts, a lot of fruits, we're looking at teas, chocolates, we're largely looking at compounds that are likely to be very enriched in the flavonols, but they're really very diverse. And I show you some of the very early papers. These are total polyphenols. And you look at the nuts, that really one of the richest nuts is our pecans and pistachios. Walnuts were part of the PreDiva trial. And when we look at the berries, we're looking at total flavonoids and anthocyanins. And we're looking at cranberries, and blueberries is very enriched in these particular compounds. So my colleagues down in Indianapolis said, you know, consistent with this theory of neurodegeneration, cognitive stress, blood pressure measurement, blood glucose, all these things are common with the usual foods that people eat. In the States, we eat less than 250 milligrams of polyphenols per day. In Europe, they have much higher ones. What if we designed a diet based on some of this earlier data based in animals and in humans, where we could actually see change in the cognitive performance of these individuals. Sorry, I keep doing that. And so we wanted to look at whether or not we could improve blood pressure, improve cognitive function, and reduce cognitive impairments. So we came up with this idea of creating a diet where we provided diet to individuals. We provided it to them, and could we measure some changes in cognitive measures and some of these other oxidative damage measures, and show that people could actually adopt these diets and see some preliminary indications of change. And so what we designed is this 4x4, or 2x2 rather, intervention arms, in which individuals can select diets that they will have delivered to their home, and also if they're randomized to this particular intervention, they will either get the speed cognitive training, or they'll have simple games that really don't involve all the cognitive aspects that we know are involved in executive function. Or the individuals will get basically equal food that's matched for calories and fat, but not those that are enriched in polyphenols. And they may get the gaming that involve cognitive training, or they get the double whammy, if you will, both the low polyphenol and the pure gaming one that doesn't involve any cognitive engagement. So this is a short-term trial without a doubt. It's only 12 weeks. This is the kind of menu that they get. If they were assigned to this particular polyphenol, they'll have choices that will be available to them because they've been assigned that particular intervention. This is all done on an iPad. The gaming is done on the iPad. And what makes this study, I think, one of the most unique studies, which also means why it's one of the most difficult to recruit for, it's looking at individuals who have low education. So we're trying to understand in those individuals who are most at risk for developing cognitive decline in AD, because they don't have that cognitive reserve, can we enhance them cognitively and diet-wise? That's the goal of this trial. I was telling some of the organizers of this earlier that our recruitment has been very tough. We're intending to recruit 180 individuals, and at this point we only have 80 individuals, and it's taken us 3 years to get these individuals. It's very tough. They're going to be followed up for 12 weeks where they get the active intervention, and then later at 24 to see a post-randomization assessment to see how many of these things are maintained after the trial is over. And these are the criteria in which they make them eligible. And I'll have to tell you, we'll have to wait to see what happens with this result. But I think this will be a very important trial, even though it's short term, to educate us about what's important here. Now, looking at all the data, I wonder whether we should have tried to recruit individuals even earlier in life. But we start at 60. So I want to end with this slide that was reported recently in the Lancet, which says, you know, we know that there is a lot of non-modifiable components that we can't change that will contribute potentially to our likelihood of developing dementia. But even in individuals who express, and I didn't even talk about this, ApoE, they can benefit from modifying diet and lifestyle. So we still have to tweak the specifics of that lifestyle, but there's no doubt to me that we can change and provide greater care with more science and more knowledge in the future. So I will close by saying in the next 5 years, we'll have much clearer picture of what behaviors we can adopt, and potentially, hopefully, I may be a little too optimistic, when we should administer those behaviors or roll out educational advice. And maybe my advice over is never too late to start this. And I'll close there. I want to acknowledge all my colleagues involved in MindSpeed, those involved in CHAP and MAP, and then all my colleagues at my institution in nutrition. And thank you for your attention. I appreciate it.
Well, thank you very much. As that was great. It's always, really great to be able to combine, reminding us how important it is to talk to our clientele about healthy eating and all those things that we normally do, but give us more background and ammunition. And so please do enter any questions that you might have. Wendy Dahl, I know you've been minding the chat box. Do we have any questions?
Yes, Julie, we have one question. The question was the correlation between omega-3 intake and cognitive health. As you talked about olive oil, can you tell us, Dr. Tangney, about specifically omega-3 intake?
Okay, there have been a lot of observational data suggesting that omega-3 actually improves cognitive decline. The 2 clinical trials that have occurred that have specifically looked at omega-3 and cognitive decline or incident dementia have been relatively short, and they have not been positive. But if you remember, when we looked at, I'm sorry, I probably messed up, but if you look at the earlier slide, let's see, should I go back, new share?
All you got to do is backslide.
Okay, back.
I mean, just
let me go back. Previous, yes. And I'm sorry, let me close this off. And yeah, let me see. I wonder if I can get to that slide quickly. If you'll see that one of the earlier multi-dimension trials that I talked about, actually the most positive data, the MAPT, which is approximately slide 50, that one, the one that had the combined multi-domain plus omega-3s, had the most positive cognitive outcomes. But I think part of the problem, there are 2 things going on here. Clinical trials should be able to answer that question, because what we don't know at this point is whether it's more important that it's DHA alone or EPA. And then when we talk about the Mediterranean or the MIND diet, most of those, by incorporating fish, will incorporate rich sources of DHA and some EPA. Obviously, when you're incorporating some nuts, you're incorporating some of those omega-3s as well. So the question is, the standalone clinical trials have not been forthcoming with regard to dementia, but I think in partly that's because we're still not clear on which supplement we might use, or maybe it should be a fish trial or a fish plus nuts trial like they did at PreDiva. So it's unfortunate, but we can't give you a firm answer on that at this point.
great. Are there any more questions? See, lots of thank yous.
All right.
So
well, I'm happy to answer them if they need to be emailed or anything else.
Great. We'll say if anything comes up, we will send it on to you. But want to thank you very much today. It was both personally very interesting, and I hope everybody else got a lot out of it. And we will see you, the rest of you, in December, on December 10th for our final session, when we link everything that we've learned with available extension programs. So once again, thank you.